All right, everybody. Hey, we're excited to talk to you today. Hello, healthcare. If you're watching us on LinkedIn Live, hello. Or if you're watching us a little bit later on YouTube, hello as well. However you're able to consume this, we're just happy that you're interested in this subject because it's a far-reaching subject. It doesn't get the attention that it deserves, but it impacts up to 25% of our population. So it's something that we need to be focused on, is these disparities in veteran care. So joining me from the Symphony RM side, our VP of Clinical Platforms, Terry Tuznik, who actually is a Navy veteran and served as a nurse in the military. Quick hey from Terry.
Hello, good morning.
And Evelyn reached out to us after we did a presentation discussion on Walmart Health. And I mean, it was a part of the conversation that I hadn't included in that discussion, but she called and we discussed at length the situation for veteran care within healthcare. Evelyn served in the Navy as a doctor and also leads the most recently. What kind of sparked this conversation is her leadership with the Veterans Health and Wellness Foundation, which provides resources and education and communication resources to aid with veteran care. So I am honored, Evelyn, to have this conversation with you, and just wanted to give you the opportunity for a quick intro too as we go into the conversation at hand.
Well, thank you, Chris and Terry, for having me. I think you did a great job with the brief introduction there in regard to, I'm a veteran myself. Terry and I both have come to know that we both served in the Navy. I was there for about 25 years and retired several years ago. And I think it was that, and at the height of the Iraq-Afghanistan conflict, where my interest and commitment to understanding the need for others to really know more about came into the spotlight, if you will, for me at least. And so I've been working with veterans and their families in relationship to their health.
Well, thank you for sharing that story. And as we go through this conversation, we'll hear more pieces of that, and we'll hear how that's evolved into what the foundation has made available. And we're going to share thoughts in terms of, I know that a lot of our audience is on the patient engagement side, or on the administrative side, or on the IT and operations side. So we're going to be thinking through what organizations can do, whether you're in a hospital or other types of organizations. But we'll be thinking through ideas on what you might be able to do to better serve and address these communities and groups with veterans. But typically how we do this, for anybody who's new to this type of conversation, is it's a live conversation. The reason that we have Terry and Dr. Evelyn here is so that you can share your perspectives with them and understand and get feedback from them about your thoughts. So any questions you have, any stories that you have, anything that you relate to that they're saying, feel free. This isn't like a seminar where you have to hold silent until the end. This is just a conversation with us all. So feel free to share your thoughts, and we'll address those and take those head on. So appreciate you being here, and we'll just go ahead and get started. Just Evelyn, with your background and like everything that you went through in the military, I'm just curious on what got you interested in like you referenced it at the height of the Afghan conflict. What got you interested in starting this foundation to start addressing veteran healthcare disparities?
Well, when I spoke about the conflict, there was evidence that those who were being cared for, even in our iconic institutions like Walter Reed and what used to be the National Medical Center and others, were at a point where they were feeling they weren't getting the care that they needed, their needs weren't being met, even though they were in military facilities getting this care. And so out of that came the understanding that they needed providers or healthcare professionals who better understood who they were, what their unique healthcare needs were, et cetera. And as we all know, at the primary or the signature injuries of the Iraq-Afghanistan conflict identified by the RAND Corporation was traumatic brain injury. And so that with PTSD and those other physical injuries, it became very clear as to why they were feeling. And so out of that came to me the need to educate healthcare professionals who were providing that care about who these people were and what their needs were. So that's where it kind of started. But as you move through that, I'm sort of a top-down, bottom-up person, so that we understand that those pieces, if they don't connect, then everybody on either end isn't really getting the message. So while we were educating the healthcare professionals on this end, we needed to also educate veterans and their families on this end, so that they understood that, a lot of what they might be experiencing may be directly caused by their service or associated with their service or associated with the care that they were or weren't getting. Because we all know that access to care doesn't guarantee you get what you need. So it was that sort of interest that said to me, a foundation needs part of this so that those pieces get addressed. And I think that a lot of that had to do with who I am and how I do patients. You mentioned that I was a physician in the Navy. My specialty was family medicine. So I don't just look at an individual or a disease. I look at the individual, whatever the issue is, injury, illness, or disease, and then the context that they represent within a family. So it was from that perspective that I began to think about the need for a foundation to address these issues.
And Terry, just a little bit earlier, you were sharing some stories as far as gaps in knowledge and different things that Evelyn's focusing on addressing. How does that story that she shared resonate with you?
So when I was a Navy nurse, I was active duty back in the 80s, and I cared for a lot of Vietnam era veterans. I noticed differences in how they approach things because of the experience that they had, being in Vietnam. And even as a Navy nurse, we were never taught really how to relate to patients who had gone through those experiences. We did have this shared bond of, all having been in the service and being active duty, but we were never taught how to care for those patients and really holistically look at them. And as a veteran, one of the things that I do is sort of an informal advocate for veterans dealing with the VA, totally different topic. But, I see where they need some care, especially our now Iraq era veterans, where they're going through different things than the patients that I even cared for in the 80s while I was active duty. So, and one thing, so to me, this is kind of near and dear to my heart because I'm seeing such a knowledge gap in how to care for these patients. And one thing, Evelyn, as we were talking a little bit earlier, I think as we have an audience out here who are not with the VA, who may not understand the impact and the amount of patients that this actually touches, not just the patients, but their families. I would love for you to talk a little bit about what we were talking about earlier, which is, who are these people? And, they are part of your community and not necessarily part of the VA and going to the VA. Would you mind explaining that again? Because I think that, the audience needs to understand these are their patients. They're a large part of their patients.
Sure. As we all know, again, depending on whose numbers you look at, there's about 18 to 20 million veterans. Those numbers continue to decline a little bit, but nonetheless, right now, we're looking at about 18 to 20 million. And of that number, only 9 million are actually registered with the VA. And I'll stop right there because that's very, very important. The vast majority of healthcare providers and allied healthcare professionals and leaders in the healthcare sector think that all veterans get their care from the VA. And that is sort of the number one stumbling block because, again, as I mentioned, there's about 20 million altogether, but only 9 million are registered. And you must be registered to get care from them. Okay, so of the 9 million who are actually registered at the VA, only 6 million actually go there and get some care. Okay, and when I say some, that's because of that 6 million, about 20% of females get all of their care there, and about 12% of males get all of their care there. The others get some there and some on the civilian side. And so that's important to know. And one of the, I think the main questions that I've asked of civilian healthcare facilities and leaders and others is that when they tell me they don't see veterans, is I ask them, how do they know? Okay, and that's a big question because they're not asking when they're screening folks. You know, it should be a part of the intake, or at least at a bare minimum, the social history, where you're asking that question, are you a veteran or have you served in the military? And if they say no, the next follow-on is has a member of your family that done so, because the family is impacted just as much as the veteran is in some respects regarding their service. And so I think it's very important to understand that really the majority of veterans are getting all of their care or a portion of their care in the civilian sector. And so it's critical that you ask that question. And then once you ask it, is that you do something when the answer is positive. There is data out there that indicates that there are hospitals that ask that question, but then they don't do anything with the information. So again, that's not helpful either. And so those are sort of the critical criteria to getting this on the right track and ensuring that veterans get the care that they need. And one other point I'll make around that same question that you asked is that sometimes when I've asked that question, they say, oh, well, we know because we can see where they have TRICARE. You know, a lot of veterans, when they come out, they have TRICARE, or there will be some indication that someone was seen at a VA facility. And so the civilian hospital or clinic will say, that's how we know our veteran population. And I say, well, that is a portion of it. But as a veteran myself, when I retired, I went to work in industry. I used insurance through the company. So there was nothing that identified me as a veteran. And I will tell you, since 2003, when I retired, I've never been asked that question when going in for care. So again, it's the ability to understand, one, that we're not all seen there. And then secondly, when you ask the question and you get the yes answer, what to do then, how to follow through on that so that you can then provide the care that that person needs.
So thank you for that. And one thing that you said earlier with regards to access, not necessarily guaranteeing outcomes or necessarily guaranteeing people are going to use those services, that really resonated. And with with a look from when you first started all the way until now, has there been any overall change, or how would you describe the state of care and availability and utilization for veterans? How would you describe the state today versus back then?
Well, it's a little difficult to give a direct response to that because, as the saying goes, when you've seen one VA, you've seen one VA. And it sort of applies to our civilian organizations also. We know that there are some, when you go to the VA, who give you excellent care, high quality, they're very attentive to your needs, they follow up, and the veterans who go there feel like they would never go anyplace else, and there's no reason to even think about it. Then there are those veterans, like the young lady I got a call from last week. She found the number through the foundation site and called me, lives in Georgia. She spoke to me for an hour without even breathing about the non-care she was receiving from the VA. She's 100% service-connected disability. So she says, I'm one of those veterans. I get all of my care at the VA, and they're just not listening to me. I'm not getting this. I'm not. As I mentioned, she went on for an hour without taking a breath about the lack of care that she was receiving And so you again, that's one facility, one patient. And so when you look at that as an overview of what's out there, you get that sort of blended response of some is excellent and some is far from that. There is no standard of quality in the VA facilities, and that's if you've seen one, you've seen one. So again, there needs to be some additional focus around quality of care across those facilities, just as we need to do the same with civilian facilities. Actually, I mean, it's no different. We have all these large healthcare systems in the civilian sector where they have hospitals all across the nation. And so they need to have some standard of quality by which they measure the care they deliver also. And I think that would be helpful to a certain degree in at least ensuring that a certain level of care is always attained. It may not always be an A+, but it's not a D either. And the other piece that I mentioned around that, that I feel is very, very important for all of us to understand, is that, Abraham Lincoln, back in his day and time, made a promise to those folks who would put a uniform on and go and fight for their country. I always paraphrase what he says because his inference was only for males who served. But his promise says that we would care for those who have borne the battle. And we're doing a very poor job of that in a lot of different places. So again, when you ask, has it improved? Some places it has, some places it hasn't. There is really no across the board measure that all of them are needed in regard to veteran healthcare.
Understood. And when you mentioned the woman who called last week and talked about her experiences, and she was able to talk to you for a solid hour and really get like feedback and have an ear that she hadn't had before, it makes me wonder about like that. I mean, that's a major accomplishment in itself. And just looking at the foundation as a whole, I'm curious about things that you'd like to highlight, because anything that you highlight, stories that you can share as far as what the foundation has accomplished, I think that's going to help inspire people to think about how they can approach within their own markets and populations as well.
Well, thank you for that question too, because I think this really gets at the core of what we do, why we do it, and how we do it. One of the things that I've come to know in being in this business of attentiveness to veteran healthcare is that there's a lot of information out there. We can debate whether the VA gives the healthcare that they need or the level of quality that it should deliver. But one thing is for sure, and that is that they have enormous amount of very, very good information out there. The problem is most people don't know it's there, and most people don't know how to find it. And so there's nothing worse than being better than sliced bread and having someone who doesn't eat carbohydrates. Okay, so the focus of the foundation is the health of veterans and their families in regard to information, understanding, and how to apply that, how to navigate hospital systems, how to navigate the VA, how to understand their service-connected disabilities and their ratings and all of those kinds of things. And so a part of what we do is curate information that's out there around those different topics. So we try to bring it to our website so that someone's going through there, oh yeah, well this is something I need right here. Or they can ask a question and hopefully if that answer isn't on the site right then, they can respond to that and better direct them. So they're not combing through volumes of information to get an answer to their question. Understanding who and where they go to for certain responses that they'll need. Oftentimes, as I mentioned, the young lady who called, we sort of give that one-on-one attention to. And sometimes the vast majority of what's needed is somebody who is listening to what they're saying. that they feel like they're being heard. That when she finished, I said, well, you know what we're dealing with here is a problem with the system. And as much as we understand that that's an issue, we won't solve that today. Okay, so I said to her, this is something we can do now that could potentially help you with what you're dealing with. And so then I began to outline a few steps that she could take, one of which she didn't know that she's eligible for TRICARE. So I said, you could apply for TRICARE as an individual. It's not a very expensive or heavy financial burden. And then you would get some additional coverage where you could go in the civilian sector and perhaps find someone there who you've trusted more. At least you could go to them to ask questions about what your care was being directed or the direction your care was headed in through the VA. And that way you could get some reassurance and feel more trusting of the folks who were providing that care. So you would have thought that I had resolved all of the years of problems that she had with the VA when it was something very simple. Again, not knowing exactly all of the benefits she was entitled to that were extremely helpful to her there. But there are a number of pathways, as I was mentioning, that we provide this care for veterans. Educating healthcare professionals. So I get colleagues of mine, I apply for grants to pay different physicians and other providers to do webinars on specific topics, everyday topics, systemic lupus, pulmonary arterial hypertension, cardiovascular disease, diabetes. All of those are diseases that impact anybody, whether you're a veteran or not. But they do have some extra added issues if you are a veteran, i.e. your risk is significantly higher if you're a Vietnam vet and exposed to Agent Orange. And so, again, as a clinician, knowing those things helps you immediately be able to understand that you should do something sooner in terms of screening or what have you for this patient who's a veteran than you would for someone else. So that's one mechanism. The other, you heard me talk about educating veterans themselves, their family members, and their community. We also have a tool. I wrote a grant, and through the Georgia Healthy Family Alliance, was awarded a $6,000 grant that helped me then position the foundation on this platform that serves as a resource to help veterans meet their other needs. The foundation focus is health, but we all know by terminology like social determinants of health, that regardless how willing that individual is to do what it is you directed them to do, or mutually agreed that they need to do, can't be done if they're losing their home, or they just lost their job, or they have food insecurity. So this platform, they can go in, it's free to them. Again, thanks to the Georgia Healthy Family Alliance. They go in, they put their zip code in, and if they're in need of food, the banner that comes up, different categories, food, housing, finance, etc. They click on food, and all of the organizations within their zip code that can help them with that are listed. And they can be directed there immediately. There is a way of direct referral, but right now we don't have the capacity to do that. They are organizations who can use a similar platform. When veterans call in, they can take that issue that they have, go through the organizations, and then directly connect them to one or two that will can deliver on answering their questions. But right now we don't have the capacity to do that, but they can use that tool and understand that all of the organizations in there are credible and reliable, and will deliver on the needs that they have. So those are ways in which we help veterans get care and other associated needs that they have.
So, Evelyn, I wanted to circle back around on two things. One, thank you so much for some of the things that you do as far as education for providers of care about the differences with veterans. I was kind of doing some research after we set up this call with you, and just really not finding a lot of education for any type of clinicians, nursing, medical students. And so I appreciate you mentioned earlier that you've done some education and getting first year and third year medical students. But, you know, because there's not a lot of knowledge about veterans and their health, you know, are there any major misconceptions about veteran health status that healthcare providers, institutions should be aware of, in your opinion?
I'm sorry, could you repeat the last part of your question? You were breaking up a little bit.
Oh, so sorry.
No.
So are there major misconceptions about veteran health status that healthcare provider organizations should be aware of?
Well, I think so. There are a number of ways to look at that. I've referred to some of that a little earlier when I was talking about the numbers of veterans who are actually seen in the civilian sector. But again, understanding that this is this group of people, this population of people we're talking about, they're very loyal to those who know them, who understand them, who exhibit a respect for who they are and what they've done. And regardless about conflicts that a country engages in and why they do what they do, the men and women, families who serve, who volunteer to serve these days, because we don't have a draft, but volunteer to serve, they need us to understand that when we're responsible for providing some of that care. And so if you become one of these organizations who has an interest, who really wants to better understand who veterans and their families are, getting the type of education or enhanced awareness that we've talked about earlier is key. But also there are other visuals, other indicators that you as an organization understand who veterans are. So while you might not think anything of it, having all the service seals or the flags that represent each of the services displayed in your lobby. When a veteran walks in and sees that, it speaks volumes to them compared to just walking into a space that doesn't have that. Those folks who we call service support personnel who sit at the front desk or your information desk, when they are greeting people, etc., they could ask, are you a veteran or have you served in the military? And if that person says yes, they can respond, well, thank you for your service. We ask that question because we want to make sure we provide you with the care that you need. Because oftentimes, again, if providers don't know that, then those certain questions aren't asked or there's no follow-on questions to gather additional information. And so those are the kinds of things that would be extremely helpful to the organization themselves, because once veterans feel they found a place where they get the care, who care about who they are, they begin the marketing and communication piece for you, because they're going to tell their buddies, and then the buddies are going to come also.
Yes, agreed.
So that's a powerful perspective, is by putting a foot forward and showing the compassion and empathy for people who have gone through those services. Like, it makes a much bigger difference than just walking into your generic hospital lobby.
Mm-hmm.
Another question that's kind of related to that is just like one aspect that you were talking about was when people are when people are first engaging with somebody who may be a veteran or may have served, asking the question. So I'm curious about anything else. Like, we had a little bit of a conversation beforehand just about the lack of overall data available. And I'm curious if you see ways that maybe providers or health systems could be doing a better job collecting the data that they need so that they can better respond and make resources available and make communication available for their veteran populations.
Yeah, I think that's another critical question in regard to data. And I use, when I'm talking about that of late, I use the example of the recent healthcare crisis we all just came out of the other end of, and that's COVID-19. And so if you were to think about it, all of the data that we have that talks about the impact of COVID-19 on the veteran population comes from the VA. Okay. We had a higher percentage of veterans who got ill, who got significantly or seriously ill from COVID, and those who died from COVID. Those numbers were higher for that population than for the general population. You all heard me say earlier that only 6 million of the 20 get care at the VA. And of that 6 million, a huge portion of them get additional care outside of the VA. So we have no real handle on how many veterans in the civilian sector actually got COVID, got seriously ill from COVID, or died from COVID. And because we know that there's increased risk in the veteran population from a number of these things that we talked about, hypertension, diabetes, obesity, all of those things that we said were put people at high risk to get COVID in the first place. So when we think about that, the question I have is how many veterans did we lose who we have no idea about, okay? Including those, again, with PTSD, TBI, all of those things, because remember, a lot of those who are getting help for their issue with PTSD and TBI do so in peer groups. They get counseling, they get support from their peers who have the same kinds of things. And they do these in-person group sessions. Well, COVID eliminated all of that. All they could do was see people like we're talking now, which was a good way to continue, but it's very impersonal, as we know. The connection is not quite there, the same as when you're face to face. And so, again, I have the question of how many veterans did we lose to COVID-19? And so if we had hospitals and clinics or what have you who were gathering that information, that would be extremely helpful. Again, if you were a facility when a veteran came in during the COVID crisis, came in, they identified, you asked that question, they identified themselves as a veteran, and then you said, well, what era did you fight in? Because that gives you huge clues as to what their increased risk for disease, injury, or illness might be. You know, Agent Orange in Vietnam, burn pits and what have you in the Gulf One, burn pits in Gulf Two, but they were burning different things, so the particulate matter differs, and sort of the injuries to the respiratory system will also differ. So you have those kinds of issues at hand that have to be considered, and that's why having that knowledge, collecting that information, and using it, not just collecting it, but using it to inform how you then interact with those who are coming to your facility for care.
So that's huge too, especially it really drives into how studies are reported and how data systems are reported as well, because if somebody looks at the statistics and figures, they might think that that's representative of the entire veteran population, but there's a gigantic amount that we don't even know based on the figures available. So it kind of raises that raises the question, raises the issue to the point where hopefully people might hear a conversation like this, or might do some additional research and find out the lack of information available and start operationalizing that to where they're collecting that early on. We are past our typical 30-minute mark, but that's pretty frequent. We just have a couple of questions left. And this one kind of gets into the core of the conversation of, hey, what are some like if we're looking for strategies or different things that we can do as organizations or healthcare leaders. I'm curious, Evelyn, what health systems you might have seen that are effectively managing this, or what kinds of strategies have you seen? Like if there's any stories, if you want to name any institutions, totally fine. If not, that's fine as well. But just curious about who other people might be able to look to as leaders in addressing veteran care disparities.
Well, there are some facilities that have begun to integrate some education of the providers that are part of their organization. That is a very good start. But as we all know, education alone doesn't necessarily operationalize, if we use what actually needs to happen. And so, you know, as a physician myself, and I'm sure Terry as a nurse, we've done CME all our lives and continue to do that. A lot of it excites us. And when we go to a conference and we're gaining information, we go back and we're all ready to implement some of the things that we learned about. And then the reality of the 10,000 emails we didn't answer when we were away are sitting there and waiting for us. And then all the other things, you know, that we normally do when we're sitting where we are or working where we are there. And so we start to get back into that routine. And then what we intended to do when we got back begins to drift further and further away. And so there needs to be reminders, and there needs to be an effective way of assessing whether or not once a clinician engages in this information, engages in the training and education, are they applying it? Okay. One, if they found it helpful, if it enhanced their knowledge, what are they doing with it? Okay. Because if they don't do anything with it, if they don't integrate it into their interaction with the patients, then nothing changes. And so the real question is, if we provide the education, enhance the provider and the allied healthcare professionals' knowledge about these unique issues around veterans and their families and their health, does that make a difference? So as they learn these things and implement these strategies in their practice, is it enhancing the outcomes of the veterans? In an example, as I mentioned, COVID-19, if facilities were asking that question when they came in, okay, and you had someone who was a veteran, they responded yes to that question, you knew they were a Vietnam era veteran. So immediately there's a very good diagram from the VA that says these are a list of things that they have agreed to now for some time that were associated with or caused by that exposure to Agent Orange. Okay, diabetes and certain cancers and all of these sorts of things. So if you know you had a veteran come in who was exposed to Agent Orange, who is obese, who has a diagnosis of hypertension, diabetes, or whatever else, you might say immediately, let's not do this and see whether he gets better. Let's immediately take him here, okay, and do X. If you had a veteran from the Iraq-Afghanistan era, and you knew they were exposed to particulate matter from burn pits, the VA hasn't come to any conclusion about illnesses, injuries or diseases they're going to associate with that. That's being actually currently looked at right now. But none of that has been defined. But we know from some of the studies that have been done that there are indications that causes significant respiratory compromise in some individuals. And so let's not wait for this guy to get bad. Let's immediately put him over here and do X because he is at higher risk, not just because of the diabetes and hypertension, but because of the respiratory insults he's had due to exposures. So those are the kinds of things that I think we miss. We do the first part, we do the CME, et cetera, but we've got to understand, we've got to track that. Are we using what we have learned? And if we're using what we have learned, is it making a difference? If not, what kinds of adjustments do we need to make? Okay, and I submit that this evaluation or collection of data needs to be going on at the same time that we are doing things, that we're actively implementing whatever it is we're looking at and learning, because veterans have waited long stretches of time to begin to even get the care that they need. They don't need an additional long runway of time for more data to be collected before they begin to get more specific care. Okay, so that's what I think about when you ask that question. What needs to be done? What can be done? We're smart enough, country, that we can do more than one thing at one time, i.e., chew gum and walk. And so I think we should utilize our abilities to do those kinds of things when we're looking at patients who are at higher risk of losing their lives. And not that anyone else doesn't deserve, I say specifically and especially for those who have defended our freedoms. So I think those are the kinds of things that civilian healthcare organizations in particular should be thinking about as we move forward and as they begin to learn more and more about this. Is yes, asking that question, understanding what needs to come next if the response is yes, or even if the response is no. And then understanding what they do with that information once they have it, i.e. act on it, don't just collect.
Love the phrasing of that. And actually, while you were talking, I noticed noticed that from our department, our manager of analytics was appreciating the post too. And I think that a perspective that we often think about on the data science side is that if there are pieces of information that might relate to risk or different healthcare outcomes, if we don't have that in the machine, then we can't make a prediction based on it. We can't change actions based on that. Mm-hmm. And it's the same thing. And it kind of translates to if somebody is operating without knowledge of like you were referencing, if I have the knowledge on has this person served and what era did they serve in, then there's a cascade of different behaviors and different questions, different actions that I would act on, but that's completely blocked out by this process. Right. I wanted to flip the same question, well, a similar question to Terry, because a big theme of this conversation and a big theme of webinars we've done in the past, we've had these patient experience panels where people have talked about their experiences, and a common theme around that is that if you don't know what like how to navigate through the healthcare system, then you're at a significant disadvantage. So I'm curious, Terry, if you've had experiences or seen, I guess, examples of health systems that are managing care well or making good resources available for veterans. And if not, then that's totally an acceptable answer.
So it's interesting, you know, as Evelyn, you were talking, I was sitting there in my brain saying, wow, if we could get that data and use that for our engagement, right, for our nurtures and nudges to our veteran populations, you know, from a data science, if we understood that they were veterans in what era, I mean, we could make guesses at the era, but it really is such critical information. And Chris, to answer your question, from a veteran perspective, I have not seen, you know, any type of additional engagement that would make that veteran's journey easier. Evelyn, when you were talking about, you know, having conversations with veterans about their options for care, again, it's something I've done informally. So happy to see your organization, because I really feel like it's such a needed, people don't understand what their benefits are, what their rights are, what the journey looks like for them. And that the fact that you're helping them do that is, you know, is just amazing. So thank you so much. I kind of wanted to end with you to, you know, do you have any final thoughts that you'd like to leave the audience with, you know, as they reflect upon this webinar? I mean, we've had such great information that you've shared, but what would you like to close with?
Well, I guess what I'd like to close with is, I don't want you to just have heard what we talked about. I want you to take what we've talked about and look at how you can do something with that information that then benefits those veterans and their families who have served. Because again, you know, enhanced knowledge, et cetera, is not the issue. I hear all the time that knowledge is power. And I counter that with, no, knowledge isn't power unless you operationalize it. Yeah. So until we take what we learn and put it in place so that it then impacts that population that we're talking about, we're really not moving the needle. Maybe we'll find out that asking this question doesn't get us as far down the line as we think so. But if we get that information, then we know we need to do more. If we never do it, we have no idea where we are. And so what I'd like for folks to take away is there is a critical need for you to take this on, to honor that promise that our country made to folks who put that uniform on, and see what we can do to actually impact and affect the healthcare outcomes that these veterans have and their family members have. And so if I could say anything, it would be, take this, what you learned from what we talked about today, look at what your organization is doing, and then understand how you can integrate it into that so that we can see some of those changes. And if you have any questions about how to do that or how you might approach it, or what kind of information is available, please feel free to contact us, because we're more than happy to have that conversation so that we can, as I mentioned, get more people the healthcare and the healthcare outcomes that they deserve.
Well, hey, we appreciate those thoughts, and I'm going to think about this all weekend, especially this one phrase that you said: knowledge isn't power unless you operationalize it. It's just potential energy sitting there, could be collecting dust unless you're actually doing something with that knowledge that you have. And we could put that as a challenge, not only to this issue at hand, but many things that people address, including like that kind of analytics domain where there's predictions being made. But once we know something, once we have an idea, an understanding of somebody's risk factor, what are we doing as a result of that? So very powerful thinking, and appreciate you coming on and sharing these thoughts with us.
Yes, thank you so much.
Well, I thank you for the invitation and for sharing this with others. Maybe we can see that we make some headway. So thank you again.
Thank you. Well, folks, that's the conclusion here, and we're going to make a transcript available on our website as well as a recording of the video. So keep an eye out for that next week. As we move forward into 2021, there are other speaking engagements, other topics that we're going to be educating on, including AI and patient engagement, data ethics in healthcare, addressing racial bias and gender bias, other things like that within AI. So lots of exciting topics. Stay tuned with us, and we will keep the information flowing. With that, thank you, folks, and hope you have a great weekend.
Thanks. Bye.
Thank you.